Our next speaker is Katie Sapp. She's a genetic counselor at the Metabolism Clinic at Indiana University, Health Physicians and Riley Children's Hospital for Children in Indianapolis. She has worked in her current role providing genetic counseling services as part of the multidisciplinary clinic to patients with all types of inborn errors of the metabolism, including those with positive newborn screenings. In this talk, she will focus on issues related to the diagnosis and recurrence risk of homocystinuria.
Hold on. There. Now. Okay, can everybody hear me? All right, it seems I have the highly sought after post-lunch talk. So I'm going to do my best to keep it light and lively and everybody awake. I know genetics is not always the most interesting of topics, but hopefully we have an audience that maybe is a little bit more interested than the average after-lunch crew. So as Danae said, my name is Katie. I'm a genetic counselor here in Indianapolis, working with patients with a variety of metabolic conditions. And I've been in this role for about 9 years. I have no intention of ever leaving it. It's my favorite thing about my job is the long-term follow-up that I know you guys are all familiar with, being part of various clinics with inborn errors. So we're going to focus mostly on the genetic side of homocystinuria today. I'm going to show you my plan of attack, and you'll notice that one of the things I am not planning to talk about are symptoms of homocystinuria. That sort of seems like preaching to the choir. I kind of feel like who knows symptoms better than patients and their families? So we're just going to breeze kind of right by that and focus on the testing, both identifying brand new patients in the family, but also looking at, who else in the family, once we've identified our first patient, do we need to be thinking about long-term? So I'm going to start by doing just a brief review of newborn screening and newborn screening for homocystinuria. We'll review the inheritance pattern of this condition. I'm sure a lot of you have heard this information before, but I think it's a helpful review when we start talking about recurrence risks within the family as well as carrier testing options. And we'll talk about screening and who should have this type of screening and when and all of those things. So what is newborn screening? This is a public health initiative that I'm really passionate about. That's aimed at identifying children, specifically babies, with a variety of conditions. We're looking at an at-risk crowd here, trying to determine who is most likely to have a given diagnosis. Every state sets its own list of conditions that are on newborn screening. I believe homocystinuria is on the screen of all 50 states. Couldn't swear to it, didn't go through and check all of their, different catalogs of testing, but my guess is that it's pretty prevalent on newborn screening. But there's a variety of other conditions. In Indiana, we screen for almost 50 different conditions with newborn screening, and that number keeps going up. The primary goal, as you guys may be aware, is to identify people who are at an increased risk for a condition based on blood levels of different chemicals. So we want to identify them pre-symptomatically, with the idea being that if you identify someone before they have symptoms and start that intervention early, the hope is that you can prevent symptoms or minimize symptoms altogether. So that testing is done by a heel stick when a new baby is somewhere between 24 and 48 hours old, ideally before mom and baby leave the hospital. So again, just a nice little colorful schematic for you, something to brighten up the room. Just the main idea of newborn screening, early diagnosis leading to early treatment and essentially improved outcomes for patients and their families. So when we talk specifically about homocystinuria for newborn screening, we're not talking about looking at homocysteine levels, which I'm sure seems a little bit counterintuitive. If you're screening somebody for homocystinuria, why wouldn't you look at homocysteine levels? Well, homocysteine is tricky to measure if you're looking at it very intentionally. But when you're looking at it in the context of 40 or 50 other conditions, it becomes even more complicated to measure a homocysteine level reliably. So we look at methionine levels typically with newborn screening. And you can see in this sort of schematic here on the side of the slide that it's part of the same pathway. So methionine is the amino acid that is broken down into homocysteine, and then that CBS enzyme breaks homocysteine into cysteine. Have I put anyone to sleep with biochemistry? No. Some of this looks familiar, right? So when the CBS enzyme isn't working, yes, your homocysteine level builds up, but it's also a backup further back in that pathway. You start thinking about the old I Love Lucy sketch where they've got the assembly line and the chocolate, and you're shoving all the chocolate in your mouth and things get backed up further and further. It's the same idea. Once homocysteine backs up so far, the methionine level starts to go up as well. So methionine is much easier to measure on a newborn screen, so that's the direction that is typically taken. That can be a little bit problematic because those methionine levels don't always rise in that first 24 to 48 hours. So again, if we're thinking about Lucy and Ethel, for a minute there, they were doing okay, getting the chocolate, stashed somewhere when they were falling behind. So if you can do okay in that first 24 to 48 hours, you may not see the methionine go up. And that could lead to a falsely reassuring newborn screen. Now, cutoff levels for methionine and for newborn screening are adjusted all the time. The idea being that we want to maximize our ability to detect individuals with the condition. We also want to minimize the number of babies we're detecting who don't have the condition. If any of you or your family members were diagnosed with homocystinuria on newborn screening, that first phone call is really nerve-wracking. It's probably, for some people, one of the worst phone calls they get. There's a problem with your baby. And we would like to minimize the number of those phone calls that we are, giving out to people unless it's actually needed. So that cutoff level for methionine levels is constantly adjusted to try and be reflective of hitting that balance of picking up as many people as possible without, bringing people in who don't need that information, don't need that follow-up. Any positive newborn screen is just a screening test. No one is ever diagnosed for sure with a given condition based on their newborn screen alone. So you would need follow-up testing with an actual homocysteine level. We do check those after a positive newborn screen. Potentially some other labs, maybe some genetic testing. But the screen itself is our trigger. It's the thing that alerts us to the fact that this baby may have homocystinuria. So going back to everyone's high school biology days, we're going to take a step back and kind of review basic genetics. So I have here 2 sets of chromosomes. You should have a complete set of chromosomes in every single cell of your body. And there are millions and millions of cells. So you have millions and millions of chromosomes, but the sets should, in theory, match from one cell to the next. There are 46 total chromosomes in every cell, and they come in 23 pairs. So one of each pair is from mom, and one of each pair is from dad. So we really are half of each of our parents. And your children really are half of you and half of their other parent. And the genes on one copy of chromosome 1 are exactly the same as the genes on the other copy of chromosome 1. The genes on chromosome 15 are the same as the genes on the other copy of 15. So with 2 copies of every chromosome, you have 2 copies of every gene. These first 22 pairs are the same between men and women. It's that 23rd pair that we call the sex chromosomes that determine your gender. So 2 X's for females and an X and a Y for males. But that's really the only difference on the chromosome level between men and women. And the CBS gene for homocystinuria is on chromosome 21. Not a fact that is important to memorize, but a fun party trick if you ever need to pull out a random piece of information. So when we talk about the genetics of homocystinuria, this is an autosomal recessive condition. And hopefully that's terminology that you've heard before, that this is not new information, that this is a recessive disorder. It's caused by changes in the CBS gene, which codes for the CBS enzyme. And for individuals with classic homocystinuria, both copies of that gene have to be changed in some way to make it not functional. So one copy from mom is changed, or the copy inherited from mom is changed, and the copy inherited from dad is changed. Now, in the vast majority of cases, parents have absolutely no idea that they're carriers for this condition. And I see some nodding heads, so I'm guessing that that's the situation here, is that this comes out of nowhere and blindsides a lot of people in the family. Once a child is diagnosed with homocystinuria, those two parents have a 25% chance with every single pregnancy they have together to have another child with this condition. Now, that 25% chance can also be presented as a 75% chance that the child does not have homocystinuria. They could be a carrier, or they could get both of those normally functioning copies of that gene. But that 25% is really the number that kind of sticks out. And that's with every single pregnancy. So if one of these couples has a child with homocystinuria, that doesn't necessarily mean that they now have 3 freebie pregnancies that they don't have to worry about. It's 25% every time. Working with a lot of recessive conditions in our clinic, I have families that have 3 children and all 3 of them have the same recessive disorder. I have families that have 8 children and it's not until number 8 that somebody is diagnosed. So it's that 25% every time, and there's no real way to predict ahead of time which pregnancies would be affected and which ones wouldn't. We do, with recessive disorders, typically see siblings being similarly affected. Now, siblings share a similar environment, they share a good portion of their DNA with each other, but they don't share everything. So there's other lifestyle factors that can obviously come into play later on. Adherence to diet, sometimes gender, all of those sorts of things, social situations, can affect how children, have symptoms of their disorders later in life. But generally that presentation and the degree of severity or their susceptibility to symptoms, we expect to be pretty similar from one sibling to the next. So this is just that same picture, but blown up a little bit more. So who is at risk in the family and who do we need to screen? So I think kind of the big take-home message is full siblings of individuals with homocystinuria are going to be our primary target of who should we be screening. They're going to be the individuals at the biggest risk. If one child is affected and picked up on newborn screening, you would expect siblings to be the same, but we can't guarantee that. And as some of you may be very aware, symptoms of homocystinuria aren't always apparent early in childhood. So we would suggest screening full siblings of patients with homocystinuria with just a homocysteine level, just a blood test. We don't want to start with DNA testing, and we'll talk about why that is in a little bit. But just screening them with a homocysteine level is sufficient to determine, do they have this condition, or do we think they fall into that 75% that may be a carrier or have 2 normally functioning copies of the gene. Parents and extended family members are not necessarily at an increased risk to have the condition themselves. They're certainly at risk to be carriers for homocystinuria, but they're not necessarily at risk to have symptoms and have the actual condition. Now, if an extended family member has symptoms of homocystinuria, by all means, they should be screened. But if they've been living their life as expected and haven't had issues with blood clots, a lot of the symptoms that maybe brought some of you who weren't picked up by newborn screening to attention, then that would be something that, we wouldn't necessarily suggest looking for homocysteine levels in asymptomatic extended family members. So looking at the general population, the carrier frequency for homocystinuria is about 1 in 250 people. So it's not the most common thing to carry, but it's also not exceptionally rare in the way we think about things in genetics. It gives us about 1 in 200 to 1 in 300,000 people with homocystinuria. So there's a whole equation to go from 1 in 200 to 300,000 back to 250, but I won't bore you with the math that I did getting here. If anybody wants to learn the Hardy-Weinberg equation, you can come find me later. We'll go through it. There's square roots involved. It's a whole thing. So I kind of took this opportunity to give you a sample pedigree. So in genetics, we do a lot of these where we draw out the family history representing, different family members in circles and squares and their relationship to each other by different lines and, kind of staggering them around. So in this particular pedigree, well, in all of them, circles are females, squares are males. In homocystinuria, it doesn't matter. It doesn't discriminate between males and females. But for the purposes of understanding what we're looking at, that's where we start here. And then the people who are connected by kind of lines overhead are siblings. And the people who are connected by lines directly left and right of them, the individual, would be like a marriage or parents having children together. So we have a little girl who's affected with homocystinuria. And looking at this, the numbers on here represent both the individual's carrier risk, so the extended family member's likelihood to carry that particular gene change. And the bottom number is the risk to actually have a child with homocystinuria based on your relationship to this affected person. So, for example, if we look at her brother screens negative for homocystinuria. He has a 2/3 chance to still be a carrier for one of these gene changes in the family. With that 2/3 chance, factoring in that 1 in 250 from the general population, he has a 1 in 1,500 chance to have a child with homocystinuria. So we're talking less than 1%, pretty significantly less than 1%, and that's for the patient's full sibling. So as you get further out from the actual diagnosed individual, the likelihood of having a child with the condition continues to go down. Just because as we get further out, the likelihood that people carry the same gene changes gets a little bit lower. It's certainly not impossible, and this all assumes that none of these people have had any sort of carrier testing. But the highest risk to have an affected child is going to remain with that person's parents, with that diagnosed individual's parents. Does all of this make sense? All right, we'll come back and go through an example with this family. And this is not based on anyone, this is pure imagination on my part. So general guidelines for carrier testing. To be informative within a family, it is most beneficial for the affected person to have had some kind of genetic testing to identify those 2 gene changes. So like we said, we're looking for 2 gene changes, 1 in each copy of the gene, and to be most informative for the rest of the family, it's helpful to identify both of them. It's also really, really helpful if the parents have had carrier testing to determine which of the changes they carry. So, for example, if mom carries change A, and dad carries change B, it's not going to be super helpful for mom's sister to be tested for change B. She's not really at risk to carry that. That's on dad's side of the family. So it helps us narrow down who should be screened for which gene changes if the parents have had carrier testing. It's not medically necessary. The difference of checking for 1 change versus 2 is pretty minimal, but it definitely can help to clarify things. It's also important to know that if the patient or your family member who actually has homocystinuria doesn't have 2 gene changes identified, that makes carrier testing really, really difficult. Because if the person with the actual diagnosis has changes that we can't detect, then how in the world are we ever going to determine if their relatives have the same gene change? We can at least check homocysteine levels for a person with the condition, but for an unaffected relative, I don't know if you're testing negative because you really don't have the gene change, or if because this gene change has just outsmarted our technology where it is right now. Genetic testing's not 100%. It's far better than it was, 5, 10, 20 years ago, but it's still not 100%. It's still not a perfect science. So it is helpful to understand, knowing the individual who has the conditions changes makes a big impact in how we can assess risk for family members. Also, both parents have to be carriers of this condition to have children who are affected. So if, we go back to that example and we're talking about mom's sister, her husband is important in this equation too. Whoever, whatever wonderful gentleman she's choosing to have children with, his carrier status makes a difference too. So checking just the family member is only partially informative when we're assessing the risk for other people to have children with homocystinuria. And we'll go through an example of that in a minute. So options for actual carrier testing. There's a few different ways that you can approach this, and we're going to go through each one. They're set up very similarly. So known mutation testing. This is one of the most specific ways to test family members of individuals with homocystinuria. So the test itself is looking only for those gene changes that we've identified in the patient, in the person who actually has this condition. It's going to tell you, is that change present or absent in whatever individual you're testing. But what it's not going to tell you is, do you carry a different change in the CBS gene? Or are you carrying changes in any other gene? It's only looking for that one unique spelling error. And if you think about a recipe in a cookbook, there's lots of places where you can have spelling errors. And if we're only looking for a specific one, you can miss a different one. Now, within a family, you're unlikely to find multiple different types of gene changes. The most likely scenario is that you would carry the same change as the individual with the condition. That's what we're looking for. But it's important to understand that you're not going to find other changes. So when we start talking about testing unaffected relatives or spouses or partners who people are considering having children with, those unrelated individuals that are also important in assessing risk, this isn't going to be a great option for them. So this is really only for people who have a family history of homocystinuria, where gene changes have been identified. Cost-wise, which is always a concern when we start talking about genetic testing, it's really hit or miss on what insurance wants to cover and what testing is actually going to cost. It could range anywhere from $0 with great insurance coverage up to a couple $100. That depends obviously on your insurance, but also on what lab you're using for that testing. And different providers have different preferences about what lab, so I don't want to give anybody specific numbers, but the labs that we're generally using are anywhere between $100 and maybe $250 for those individual mutations. So, full gene sequencing is going to be essentially spell check of the entire CBS gene. So with this option, we're not just looking for that specific change. We're looking at that entire recipe and looking for any kind of spelling errors that we can find. So this is going to detect between 95 and 98% of changes in the CBS gene. Now, that's not 100%, we've covered that, but no genetic testing is going to detect 100%. So this 95 to 98% is sort of the best case scenario here, as far as making sure you're detecting changes that are there. It will not tell you if you have a gene change that's not detected by this technology. So when we talk about the actual affected individual, the actual person with homocystinuria in the family having gene changes we can't identify, if we didn't identify it in them, you're not going to be able to identify it in family members, even with gene sequencing. It just falls into that 2 to 5% that we can't detect with this test. It also will not tell you if you have changes in any other genes. So I've had families come to me before and they said, well, we have a family history of cystic fibrosis and I had genetic testing. How does my baby have homocystinuria now? Well, it's a totally different gene. And with this particular test, we're only looking at the gene for homocystinuria. So this is appropriate testing for individuals who have a family history of homocystinuria where maybe we don't know mutations. So maybe it was a distant relative that we're not in contact with. Maybe it was somebody that was diagnosed a long time ago and doesn't have, never had genetic testing because the availability was so much different 10, 15, 20 years ago. So this would be appropriate for somebody who has a family history, but we don't have access for one reason or another to the actual diagnosed person in the family's genetic testing results. This is also very appropriate for those partners, for the people who have come into the family who don't have a family history of homocystinuria in their own family, but their carrier status is important when we're talking about recurrence risks. So this testing can range anywhere between $200 and $500, which has come down a lot over just the 9 years that I've been working in genetics. It used to be single gene testing could be anywhere between $700 and $2,000, and now we're talking a few hundred versus a couple thousand. So a newer option for carrier testing in just really anyone. So the general population, regardless of your family history, we've started offering families and couples what we call expanded carrier panels. So these are going to be multi-gene panels that their original intention was to help couples who are thinking about expanding their families, but who are concerned about having a child with a genetic condition for one reason or another. Some people have a family history. Some people have friends who have had a child with a condition. Some people are just genetic counselor nerds who are very nervous about things because we've seen too much. So it can be any number of different reasons why people choose to pursue this kind of testing. But these are going to be panels that have several hundred genes on them. Not just one gene for homocystinuria, but potentially that gene and 200 or 300 others, depending on what panel you choose, that we're looking at all of them. So this would tell you if you carry a change in any of the genes that are included on the testing. It's not going to tell you if you have a change in a gene that's not on the panel. Obviously, looking at 200 to 300 genes is a lot. But when you consider that you have 25,000 genes in your body, it's a pretty small percentage of those. It's also not going to tell you if you have a gene change that's not detectable by this technology. So we always go back to, we can't guarantee that every gene change is going to be picked up, even with a positive family history, even when in a person who has an actual diagnosis. So this testing is available to anyone. I've used this testing for couples where one member of the couple has a family history of a condition, the partner does not, but they want to be tested together and they want to see not just about that condition, but everything else. A lot of times they've talked to their parents about that experience of being really caught off guard by having a child with a genetic condition. So they're concerned not just about the condition that's been in the family, but anything else that they can get information onto. So this is really geared toward information-seeking kind of people. And most labs have maximum out-of-pockets for this sort of testing if they're offering it. So that can be anywhere between $300 and $500 per person. So for $1,000, you could have both couples screened for 350 different conditions potentially. Now, not everybody wants to know about those other 349 conditions. Some people have very specific conditions in mind, and if that's all they want to know about, this may not be the best test for them. So if you do have a specific condition that you're interested in, you want to make sure it's included on that particular panel because they don't all have the same things. So if you went to a doctor and said, I want expanded carrier testing, I have a family history of homocystinuria, and they said, okay, we send our panels like that to lab X. Okay, great, sounds good, let's do it. Well, lab X's panel doesn't include the gene for homocystinuria. That's going to be important to know. You want to make sure that you're getting tested for the conditions that you're concerned about. So that would be the one kind of caveat, the one cautionary tale that I would give to you guys as you consider this as an option in your family. So why and when should we be pursuing carrier testing? So this is done to better clarify the likelihood to have a child with homocystinuria or a different genetic condition in the context of those expanded panels. Carrier testing, we feel really strongly in the genetics community, is a personal decision that should be made by adults who understand the testing that they're asking for. This goes back to looking at siblings for individuals with a diagnosis. We understand that as parents, you feel like you should have the right to know if your child's a carrier. But we feel really strongly that your child may not want that information in 20 years. Everybody perceives their risk differently. So we want each individual to make the decision of whether or not to learn their carrier status for themselves. It's totally voluntary, and as genetic counselors, I've met with families before and family members who, after we kind of talk through everything and the testing options and the information that it can and can't tell you and what those risk numbers actually are, some of them decide this isn't the right test for me, I don't want this information, and that's okay. As long as they're making the informed decision of whether or not they want it, that's our goal as genetics providers, is to make sure that anyone who wants the information has access to it. So occasionally, we say carrier testing should be voluntary, but occasionally we can determine one family member's carrier testing or carrier status based on the testing results of another individual in the family. So this most of the time happens in the context of the adult child of a relative for one of these people that can tell their parents' carrier status. So if we go back to this pedigree that we were looking at earlier, and we look at these individuals, we've got the mom's aunt and the mom's cousin kind of circled. So those two females. And the cousin is interested in starting a family, and she wants to clarify the likelihood for herself to have a child with homocystinuria. So her mother doesn't know her carrier status at this point. Her mother's not particularly interested in that. She says, either I don't want to know, or if her child's having children, she's probably done having children. She might be in her 40s, 50s, 60s, even older. We don't know. But without knowing mom's carrier status, this cousin started with a 1 in 8 chance to be a carrier and a 1 in 8,000 chance to have a child with the condition. So if she chooses to pursue carrier testing and that testing is positive, saying that she's a carrier, that would tell us by default that her mother is also a carrier. So if I go back to this, gene changes don't skip generations. They don't skip people in families. If a child has one of these gene changes, one of their parents had to have it too. So it's not that the cousins can have the gene change and their parents don't. It's very direct from one generation to the next, from one individual to the next. If her mother had had carrier testing and was negative, then we would say she doesn't need carrier testing because you can't pass on changes you don't have. So if that testing is negative for this cousin, it doesn't tell us a darn thing about her mom's carrier status. So it's only if it's positive that it's revealing for her. If it's negative, she could still be a carrier and just didn't pass that gene change on. Or she might not be a carrier and the cousin was never at risk in the first place. But we don't know that information without actually testing that individual. It's also important to note that for the cousin, she's got a brother as well. Whatever her test results show has zero impact on her brother's results. So if she's negative, if she's positive, that doesn't really do a whole lot to change her brother's risk. If she's positive, that tells us mom's a carrier, so the brother's risk goes up to be a carrier, but it still doesn't guarantee that he's a carrier as well. There's that 50-50 chance to pass it on if you're a carrier. So it can help to clarify the likelihood, but like we've said a couple of times, both parents are important. So if a family member has carrier testing, their partner needs to have carrier testing as well to be fully informative. Now, if the cousin had tested negative, I don't really care if her husband's a carrier. It's interesting information to have. If he wants to be tested, go for it. But if she doesn't carry those gene changes, there's no medical indication to test her partner. We don't really need that information anymore because their risk has just gone down significantly. So for partners, we're really looking to see, is the family member a carrier first? And then we can look at the unrelated partner who's coming in. Now, if there are any shared relatives, so I work a lot with the Amish population, there are shared relatives, and you can see cousins overlapping places. We won't go into specifics. It's right after lunch. Nobody wants any of that information. But I also grew up in southern Indiana, where you have really nice, large families. And sometimes you can have, what do we call them, double first cousins. So mom and her sister married dad and his brother. There's no sketchy genetic things going on there. All of that's totally on the up and up. We're not at an increased risk for some of the things that happen if you have children with a related individual. But because they're both at a risk to have, to carry these same gene changes, you have to think about those people a little bit differently than if someone who's completely unrelated is coming into the picture. So all of those things affect the risk assessment that we would give people. So what steps does someone take to pursue carrier testing? The first step for us, from our perspective, my first question is always going to be, do we have the results for the affected individual? If the answer to that is no, hopefully talking through all these options, you figured out that doesn't mean that we can't move forward. It just means that we might not be able to be as informative or as reassuring with other individuals. So our first step is always, do we have testing results from the individual who's actually been diagnosed with the condition? Second step is talking to your healthcare provider. So for most people, that's going to be either their family doctor or for women, their OBGYN. Most OBs are familiar with ordering different types of carrier testing, but usually not things specific like homocystinuria. They're looking at conditions that are a lot more common in the general population, things that the American College of Obstetrics and Gynecology, or ACOG, has said everyone should be offered screening for this. Homocystinuria is not on that list. So you may throw these individuals for a bit of a loop if you come in asking for genetic testing for a rare disorder that they maybe haven't heard of since medical school. So if the primary care doctor or the OB is in any way uncomfortable either ordering the test or talking about the testing, then it's well within your rights to say, could you please refer me to a genetic counselor? Either someone who works in a metabolic setting like myself, or most genetic counselors working in the prenatal setting are very familiar with this type of testing as well. So meeting with a genetic counselor can be a great option if your primary care provider isn't particularly comfortable moving forward with this sort of testing. For some people, they say, you know what, it's genetic testing, I'd like to talk to genetics first, and they kind of want to bypass that step. And that's okay, we're happy to talk with someone, we just usually need a referral. So you can always just ask for the referral rather than asking for the test as well. That's very legitimate. So kind of step 4 here is when we get to the point of talking about testing and ordering testing, you want to make sure that whatever test you're ordering is going to provide you the information that you're interested in. So we've talked about the 3 different options for carrier testing, and you want to make sure that whatever test you settle on is really going to give you that information. Is it really going to tell you whether or not you're a carrier for homocystinuria or not? Is this the best test for you in this setting? And sometimes, unfortunately, the OB or the family doctor isn't the best person to kind of help clarify the difference between one test or another, and that's where genetics providers can be really helpful in that process. So between the provider who actually winds up ordering the testing and the lab performing the testing, there should be resources available for you to help determine what's your coverage, what's your out-of-pocket responsibility. How much is this going to cost you? What are the dollars and cents of moving forward with carrier testing? So reaching out to them and saying, hey, I'm interested in doing this testing. I think this is the best option. What's it going to cost? And in the vast majority of cases, they can give you a dollar amount out of pocket before a sample's ever obtained. So step number 6 of 7 is actually submitting the sample. There's a whole lot of thought and planning and work that goes into getting there, but actually submitting a sample is the second to last step of the process. So that could be, depending on the test, a blood sample. We do a lot of it on cheek swabs as well. So you can, DNA is in every cell. So there's different options on what type of sample you can submit, and that's something that you would work with the ordering provider on. So once you submit a sample, most carrier testing usually takes about 2 to 3 weeks to come back, and the results should come to you from whoever ordered the test. So if your primary care doctor ordered the test, if your OB ordered the test, if you saw someone in genetics and they ordered the test, that's the person that you should be getting results from. That's who the results are going to go to, and then they can call you and talk through the results again and explain what the implications of that result is. So that's sort of steps 1 through 7. Now, as a genetic counselor, I sort of felt the need to put a pitch in for the profession. Let you all know we can be useful. My primary role is to explain genetic conditions to families, to when you have a child diagnosed, explain what does this mean for you and your family. But obviously that turns into these types of conversations. So to involve a genetic counselor in this decision-making process has some advantages. A GC can provide you the information, kind of talk through each of these tests with you, and help you make the best decision for yourself and your own healthcare. I don't want to make a decision for you, but I want to make sure that the decision you make is informed, that you know what you're getting into, and you're getting the information that you are most interested in. So we can talk through the options and understand, make sure that you understand what it is that we're moving forward with. We also do a lot with helping to coordinate the coverage for testing. It's by no means my favorite part of the job, but we're willing to help do that anyway because we feel so strongly that you should have access to the information you want. So that's a very common thing that a genetic counselor would do, is to help ensure coverage or determine what your out-of-pocket responsibility would be. Genetic counselors will also help coordinate sample submission. So there are test kits, there are different blood draw site options, various factors that go into doing that, and we can make sure that we can set up something that is as convenient as possible for whoever's pursuing testing. Discussing results sort of seems like an obvious thing that a genetic counselor would do. You think genetic counselor, genetic test results, yeah, we should be able to have those conversations. And we do. So we can talk about, well, in light of this result, your recurrence risk is now this %. Either it goes up, it goes down, it stays the same. It's hard to say. But we can sit there and go through specifically what are your individual risks based on these results and answer any kind of follow-up questions you have. Like, okay, so now I know I'm a carrier for this. What are my options? What can I do? And kind of help move forward with that information. We can also help connect patients and their families to other individual resources. So the Homocystinuria group, you guys are an excellent resource. It always makes me really happy when there are active parent groups for rare disorders. told people more than once, I see you in clinic a couple times a year, maybe, and we can offer advice. You know, our dietitians tell you a lot about what you should eat, what you shouldn't eat, but those tricks of the trade, the nuances that come from either having a rare disorder or raising a child with a rare disorder, we're not there every day. We don't fight this battle on the front line, so to speak. So when there are parent groups that we can refer our patients to, that makes us really happy because we know that there's someone who's walked in their shoes and can help them through that. So if we were to find someone who is at risk to have a certain condition, looking for other parents who have been in that position before is something that I'm going to want to do as a genetic counselor and let them talk to someone who has sat where they're sitting. So to kind of summarize everything, homocystinuria is an autosomal recessive condition that we are screening babies for at birth across the country. Gene changes for homocystinuria can be passed through a family for generations, and no one knows. They're silently passed until the right family member has a child with the right member of a different family. So carrier testing expands from an affected individual versus just sort of happening out of nowhere. The likelihood that somebody's a carrier is really dependent on how they're related to the person with the diagnosis. And carrier testing is available and is becoming more and more affordable to family members who are interested in that information. So there's several different options for carrier testing and for family members and their partners to choose from to decide what's most appropriate, what's most informative for them. And a genetic counselor can help explain any of these options to you so that you can choose the one that is best for yourself and for your family. So, with that, I think I wrapped up right at 10 minutes early. If anybody has questions, comments, thoughts, it's a pleasure to present to you guys. Yeah.
Do you have any statistics on how many people have homocystinuria in different states around the country? Because where we are from in California, especially my son's clinic, he's the only one.
Sure.
And I haven't heard of that many people in along the west part
The West
of
Coast.
the country. So it's, and from your statistics, you said like in general population, 1 in 250, that's a very high number. For that, you have 1 in 300,000 occurrence rate of homocystinuria or the diagnosed people. So I can't really connect those two.
Sure. So for anybody that couldn't hear, the question is, are there areas of the country or state by state where homocystinuria is more prevalent? Because this 1 in 250 sounds too common to be so rare. Is that accurate, your question? So I don't have state by state numbers. I can tell you that in our clinic, oh my, that's interesting. In our clinic, we have probably with classic CBS homocystinuria, because you've probably figured out there's different types. Everything here today was specific to CBS. But with that particular gene change, we probably have maybe 4 or 5 patients. But we cover the entire state of Indiana. So that's 1 of 50 states. Indiana's not a huge state, it's hard to say. In California, you're probably going to have multiple clinics that are working with homocystinuria patients. So that's going to be a factor. It's also possible that you're going to have people who are undiagnosed, who have no idea that they have homocystinuria. So those numbers are all contingent on looking at carrier frequencies, looking at how many we see, and thinking about, is there anybody that's maybe silently affected with this condition who could be having symptoms that they just haven't seen the right doctor to recognize? You know, if you think about somebody in a rural area who has recurrent blood clots, they might not see a doctor who's familiar with homocystinuria, who thinks about that diagnosis. So it could be underdiagnosed. And that 1 in 250 carrier frequency also depends on finding another person who's 1 in 250. So then we start multiplying those numbers together. And then it depends on that 25% chance So all of those things multiplied together take you from 1 in 250 to that 1 in 2 to 300,000. So for something that sounds common as a carrier frequency, it doesn't always, when you look at how the risk numbers pan out, it doesn't always translate into something that actually winds up being common.
Do you want to talk about ethnic variations where there's higher risk in certain ethnic variation, like Irish, like
Sure.
the Irish travelers, Qataris?
Sure. So the question was different ethnic groups, do we see this more frequently or less frequently? So in general, with recessive conditions, sometimes you see certain populations that are more affected. Where we see that are populations where we call them closed populations, where you marry individuals who are of the same group and they're smaller groups. So I referenced the Amish population that we have here in Indiana. It's a small group, but you don't see many individuals of the Amish population marrying and having children with individuals outside of the Amish population. They tend to marry within their own group for lots of reasons, but with that, they become more and more related to each other with each generation because you start to run out of unrelated options if you're not willing to look outside of your population. So there's a variety of groups. The Ashkenazi Jewish population has several different conditions that they carry more frequently. Traveler populations, the Qataris. Yeah.
It can be 1 in 25 in certain families.
Yeah.
And then the Irish population is 1 in 64,000.
Okay. So within those groups, with the Irish being 1 in 64,000, that 1 in 250 is going to change a lot, and the mental math is not going to work out well for me right now. I apologize. 64,000 is like 1 in 800, so it's like 1 in 40-ish, if my mental math is panning out correctly. Does that sound like familiar numbers to you guys? So when we start looking into populations that have an increased risk for these gene changes, then you're going to see that go up. So the population of California, there are some Irish individuals out there, sure. But if you look at the East Coast population, where you see a lot of Irish immigration from potato famine and other things that happen there, you're going to probably see a higher rate of homocystinuria in that area. So when you have different ethnic groups that have an increased risk, wherever those groups are settled is where you're going to see pockets of higher frequency of these conditions.
Question in the back?
Yeah.
You mentioned for our genetic testing, it wasn't super clear. They tested us and they said the 2 main mutations, you don't have those. Here's one that we think is the one from the dad, here's the one we think from the mom.
Mm-hmm.
So probably those are the 2 mutations in the gene. Is that normal? There's not that many HC people out there that the genetics database doesn't know for sure that's the mutation.
Sure. So the question was, it sounds like there's some ambiguity, that your mutations weren't clear cut. Did they use the term like variant of uncertain significance?
Yes.
Okay. That's what I thought you were getting at. I just wanted to confirm. So we have variants of uncertain significance in our family. What does that mean? So working with rare disorders, variants of uncertain significance, or VUS, is a very common thing that we run into. With metabolic conditions, we have the luxury of having other testing to confirm things. So we can say that individuals with both of those VUSs have elevated homocysteine levels. So that tells us that these changes are more likely to be what we call pathogenic, disease-causing. It's tricky because for a lab to call a gene change disease-causing, it has to meet certain criteria. And one of those criteria is that gene change has to have been reported before. You have to have seen other patients with it to really call it a true pathogenic mutation. It needs to be reported previously. So for rare disorders, where you've got a lot of different gene changes that can happen within a single gene, you don't always have the luxury of numbers for other patients having those same changes. Now, there are some gene changes that we see repeated over and over again, and a lot of times you see those in these closed populations that we talk about. So there's probably 1 or more common mutations in the Irish population. among others. But for people that don't fall into those populations, you see more of these unique mutations or unique variants within a family that are individual to them, but maybe haven't been seen before. So we run into VUSs really frequently in our role, and for the most part at this point, I'm really unfazed by them. If you see 2 changes in a patient that has that condition, you certainly want to make sure you fully investigated the gene, which it sounds like your clinical team has, and making sure there's not something more subtle hiding there. But if you've got 2 changes, you've got symptoms that fit, we know 1 change came from each parent, that's huge in helping us interpret those. So it's not uncommon to see variants of uncertain significance for rare disorders.
Making sure that the clinician knows about the database. There was a website that young Kraus had, who recently passed away, housed out of Prague, so you have to have access to the international. But we both have contacts that could help, where Jan had collected over the years all of the known mutations to actually cause clinical disease, and it's on a website. I don't know how accessible that is, but if your provider doesn't know about it, get a message to one of us and we can connect you with the right people.
Yeah. So there's a database, it sounds like, of homocystinuria specific mutations.
CBS deficiency.
Okay, so CBS specific mutations. There's also other databases for essentially all clinical genes, but a lot of times the groups that are working in specific disorders have way more knowledge of these gene changes than the generic. ClinVar is our big kind of online resource for various genes that we'll reference. But I think the database you guys are talking about is probably going to be more useful in this setting. And at the very least, it gives you the opportunity to have those changes put into the database so that if they're ever seen again, this sort of mystery that has surrounded your genetic testing may help benefit another family avoid that mystery if you get those changes put in there. So I think that's a great thing to do as a way of helping other individuals who are in similar situations.
One other. So I had something happen in New York State as it relates to carrier screening, and I'm just wondering how prevalent this is.
Sure.
I can figure out how to deal with my
Yeah.
issue. So I'm originally from New York State. I don't live there now. I have 3 sisters there who are carriers. And so I'm helping get their children tested when they're old enough and want the information. And it used to be easy to do. We could do it through the University of Colorado lab. Just, you know, first was a blood test, then it was a buccal swab. And then all of a sudden I went to get the next child done and was told by Colorado, nope, we can't do anything for New York State residents anymore. New York State won't allow it. So I contacted the metabolic clinic in Buffalo where my sisters had been treated that I knew, and they said, okay, let us check into, you know, we haven't done this in many years, let us check into where to have it done within New York State. There is not an authorized provider. Now, Marcia told me that may have changed very recently. But anyway, what I was told I had to do was to get a waiver, and I went to the website, and I'm pretty good at paperwork, but I was so overwhelmed by all the forms and everything that I've essentially just put it off until I have the time to really focus on it and figure out all these forms. Now maybe Marcia has a new, easier way, but can you comment on how common is that throughout the country, and should people expect to have to go through hurdles like that to get this done?
So what we're referencing is New York State. We had individuals who are at risk to be carriers in the state of New York who previous testing had been done at a lab in Colorado. We wanted to send additional testing for family members that are now in adulthood, and they're running into a brick wall saying we can't take samples from New York State. I will tell you, this is a unique problem to New York State. I don't know I don't know the specifics of why this is a problem because I practice in Indiana, but I can tell you that just about every single genetic testing requisition that I fill out as a clinician has a caveat on there for residents of the state of New York. It's a unique issue there. I don't know who made what law to make that a problem, but in the other 49 states, you should be good to send testing wherever you want.
Thank you.
Sure.
So the testing can be done, I mean, I can send a sample from California to Denver and then
Absolutely. So testing, patients can be located in any state and we can send testing out of state. So that's commonly done. In Indiana, we don't really have, our university health system has genetic testing for certain conditions, but it's by no means comprehensive and frankly, it's by no means affordable. So the larger commercial labs, there's a couple in California, there's a couple on the East Coast that have the programs that make they have the volume to make the testing affordable to patients. We send testing out of state, I would say, from our clinic almost every day of the week. It's really, really common to have samples cross state lines.
And you can coordinate testing from an out-of-state to go someplace. So you can coordinate a parent who lives in Florida for a kid that's diagnosed in Indiana.
Yes. So you can coordinate testing across state lines. Different clinicians have a different level of comfort with doing that. In our clinic, we don't like to order testing on patients that we haven't actually seen. So if you had, let's say the family lived in Indiana, but dad has a sister that lives in Iowa, ideally I would like that individual in Iowa to see someone local to talk through everything and kind of sit down. Just because we want to make sure that decisions are informed and we don't feel like we have a great ability to do that for people that we haven't physically been able to see or have extensive conversations with. So that's the preference in our clinic. That may not be the preference in every clinic. Yeah.
And just to clarify, patients need to go through a clinician to request a test. We can't just contact directly.
Yes. So this is testing that needs to be ordered with a doctor involved. This isn't, when you think about like 23andMe and Ancestry.com, that's not going to be the ideal way to pursue carrier testing for conditions like this. Direct-to-consumer testing has some regulations on the information that they can report back to families and to patients or individuals that are pursuing testing. So you really want to make sure that you're using a clinical lab with the assistance and supervision of a physician.
Right, but I will say, having done it for many family members, these family members aren't being seen by a geneticist or a metabolic clinician because they're the children of a carrier who's not even being seen by that. So what I have found is you can go, for example, to the Denver lab, and I have the contact information, but Jan Kraus designed those tests, so I had very high confidence that they knew what they were testing for since he maintained the website of all the mutations. You can go to their website and you can get the forms, and one of the forms the provider then has to sign. So what I did was gave all of these forms to a sibling who's a carrier and said, okay, you need to help your child get their physician's office to sign it. Because the physician's office didn't have a clue. They might have remembered, what homocystinuria was, but they wouldn't have known how to have that conversation.
Right.
So you can lead the process on your own, but you still do need a provider to sign off on that, and the provider will get the results and then give them to you.
All right, let's give